Hello, I am Dr. Luigi DiBiase from the Albert Einstein College of Medicine at Montefiore Hospital in New York. And we are here today with the editorial team of the AACC.org to comment the most important trial from the ESC 2021. I'm the pleasure to have with me two friends, Dr. Kim Birtcher from the Houston College of Pharmacy and Dr. Julio Panza from the Westchester Medical Center and New York Medical College. Thank you very much. So we have selected today to comment some of the most important trial that we feel can give like a change in clinical practice. You will be able to find a full summary of the trial online, but you will hear from us a few important teaching points. So we will start with the first two trials that pertain to the prevention, and we will talk about the STEP trial and the IAMI trial. So, Kim, how do you think these two trials will change your clinical practice?
Well, thank you for the question. I think the main thing that we learned from STEP is that it reaffirms the importance of lowering blood pressure in our older patients. In STEP, they targeted a more intensive systolic goal than in the control group. And as a result, there were fewer cardiovascular events. We saw this in SPRINT. It was included in the blood pressure guidelines, and as in SPRINT and as mentioned in the blood pressure guidelines, it's important to monitor patients for hypotension because not all patients can tolerate that lower blood pressure. If we think about the IAMI trial, here again, we have reaffirmation of the importance of giving an influenza vaccine to patients with CAD. In this particular trial, they focused on patients that had had a recent AMI and they were hospitalized as a result. The vaccine was given during the hospitalization, so it was given early on after the event, and they did have fewer cardiovascular events. Now, giving the flu vaccine is not new. It was included in the 2011 secondary prevention guideline. I think the key thing for cardiovascular professionals is to remember to encourage our patients, especially during flu season, go ahead and take that vaccine, and they can take it while they're in the hospital.
Well, thank you. I think they're really too provocative study, and what intrigued me is when you try to lower the blood pressure, how much patient can be compliant, how much they can keep a low blood pressure or lower blood pressure over time. What do you think is the trick here?
Well, I think we see time and again it takes multiple medications to get the blood pressure to that target that we're shooting for. A lot of times when you add extra medications, we see adherence problems. So it's one of those things we need to remind patients why they're taking the medications and the importance of taking those medications.
And also for the other trial, the influenza vaccination trial, do you think? I mean, that the plaque can become dangerous with an infection is an accepted information now. Do you think that other type of vaccine can also be influential over there? We are getting the COVID-19 vaccine or other type of vaccine. Do you think that there's more there to learn about that?
I think there's definitely more to learn, especially as far as the mechanism of action. We don't know exactly why, it works in this patient population. It may be related to inflammation, it may be related to other stress factors, but we don't know exactly why. But time and again, we see the importance of these vaccine preventable diseases and the importance of getting these vaccines in our patients with ASCVD.
Thank you very much. Let's move to SHD trial. And Julio, maybe we can select the Tomahawk and the Master DAPT trial. I mean, what do you think is the key message of these two trials?
I think the Tomahawk trial is an important one because of the preconceived notion in many hospitals and among many interventional cardiologists that if someone has a cardiac arrest, the patient should go immediately to the cath lab. And as you know, the results of this trial showed that routine immediate coronary angiography does not necessarily improve the outcome of patients, in this case without ST segment elevation on the first EKG after return of spontaneous circulation. This is very similar to a recently published study, the COAC trial, although the COAC trial only included patients with shockable rhythms. The TOMAHAWK trial included patients with and those without shockable rhythms as the first detected rhythm. I think that these trials, I think, in a way, go against that myth that everybody should go to the cath lab, which is based on the previous observations that most patients that suffer a cardiac arrest have a ruptured plaque in the coronary arteries when they go to examine the specimens of the heart. If you look at the Tomahawk trial data, this may explain why this strategy doesn't work. First, only about 40% of the patients had actually coronary artery disease that was interpreted as the culprit for the event. Accordingly, only 40% of the patients had PCI in both groups of the immediate or the delayed coronary angiography. And finally, and perhaps the most important thing, is that most patients died of anoxic brain injury, which means that even in those patients with clear evidence of a culprit vessel treated with PCI, the ultimate benefit of coronary angiography is not realized and is limited due to the lack of neurologic recovery. Interestingly, though, in Tomahawk, even when patients were stratified in terms of shockable rhythms or non-shockable rhythms, that didn't make a difference. So I think that the use of immediate angiography, in my mind, should be reserved for very selected patients after a cardiac arrest. Those in whom an ischemic etiology is very strongly suspected because, for whatever reason, obviously presence of ST elevation is a very important reason. Those that had immediate bystander CPR, so that there is greater hope for neurologic recovery. And I still think that the presence of a shockable rhythm as the initial presentation is important.
Kim, what's your take on this trial?
I agree with what's been said already. I think it's interesting that here again we're seeing that there was no difference in the all cause mortality, and I think it's really important to assess the patient's neurological function before you send them to the cath lab for something that they may not be able to recover from.
And Julio, one, for the sickness of time, we try to be short, but what's your key point on the master DAPT trial? What do you think people can go home with this trial?
Well, I think it's a difficult question to answer because this is clearly a moving target. So the master DAPT trial supports the use of a shorter duration of dual antiplatelet therapy. But it is important to realize that these were very highly selected patients. First of all, they all had high bleeding risk. They all had implantation of a biodegradable polymer stent. And critically so, they had no ischemic or bleeding events within the first 30 days after PCI. So patients were randomized after the demonstration of 1 month of clinical stability and not before the procedure. This is critical when you approach a patient and before you do PCI. And this must be weighed against a number of other trials that showed that dual antiplatelet therapy and even use of low dose anticoagulation in patients with high cardiovascular risk is beneficial. So, how do you balance the shorter duration of DAPT against the demonstrated benefit of longer duration of DAPT? And obviously, that requires individualized treatment, balancing the bleeding risk, the ischemic risk, and I don't think that there is a recipe for every patient.
And since we are talking about bleeding risk, I think we can connect with the two uh, arrhythmia trial. We start with the loop trial, which summarize. You know, we have to detect more atrial fibrillation. Well, once we have more atrial fibrillation, what we have to do? Kim, what would you say on a prevention point of view about the loop trial?
Right, right. I think the jury is still out in identifying that time period when it's critical to initiate that anticoagulation therapy. In the loop trial, they aggressively monitored for AFib, and when you look for it, you will find it. And then they initiated anticoagulation therapy. However, the net clinical benefit was not clear from doing this. They did identify patients who were at high risk for thrombotic event from AFib. They had an age as a risk factor plus an additional risk factor. About a quarter of the patients had that implantable loop recorder looking for the AFib. However, the clinical benefit at the end of the trial, there was really no difference in the results as far as benefit or safety.
Uh, I, I completely agree with you. Although I think, despite there's a kind of contrast between cardiologists and neurologists, we like to implant a loop recorder in a patient with, I don't know, a cryptogenic stroke and start AC. And then if the patient doesn't prove AFib, we like to stop it. Why? On their side, they like to implant loop recorder and do not start anticoagulation before you diagnose atrial fibrillation because they're more worried about the bleeding. That's why I try to connect you with the DAPT trial. Um, uh, my point is that there's not only stroke, there is also dementia, there is also Alzheimer. So I think that detecting early atrial fibrillation or short episode atrial fibrillation, we should not only look at the stroke, but we should look also prevention of other form of neurologic impairment. And I think longer follow up, more data. I mean, the dog for sure have reduced the bleeding risk, but not completely eliminated. We have closure device like appendage closure device. Do they add something here for the bleeding? I mean, I still think that we have to learn a lot more, but for sure the more you look, the more you find, and we will find more atrial fibrillation, and we need to know what to do with this atrial fibrillation. Treat it or don't treat it. I think the answer has to come as of yet. That's what I really believe. And last but not last, we have the EAST-AF trial. This is a trial that have proven something that for somebody like me that do ablation and believe in sinus rhythm is reassuring, meaning atrial fibrillation is not a nuisance. And the earlier you can restore sinus rhythm, the better is for the patient cardiovascular total cardiovascular risk at least. So I feel that early intervention is necessary and restoration of sinus rhythm is very important rather than you can stay in AFib, nothing will happen to you. I have to say that ablation works much better than medication in restoring sinus rhythm. So I think we should ablate early before it progress to persistent, before patient become older and become more difficult to be managed. What is your point, Julio, on this?
I completely agree, and I think that it's not only the results of the trials, but the clinical experience that one has, and I completely agree. I think that the thought that rhythm and rate control are the same thing is fading away, and I think that these trials provide a great support for that concept.
How about you, Kim? What do you
I
think?
don't have anything to add. You covered it.
Okay, so I hope that this video was useful for all of you. Full details of all the most important trial from ESC 21 will be on the acc.org webpage. Thank you very much for your attention.